Welcome, everybody. My name is Dr. Donna Reece, and with me is Dr. Arleigh McCurdy. Dr. McCurdy will be reviewing abstract number 413, which is the report from the CMRG 004 trial, which compares in relapsed refractory myeloma patients a quadruplet with a triplet regimen in which the fourth agent is added only at relapse. Welcome, Arleigh.
Thanks, Donna. So this CMRG trial included 120 patients who were randomized 1-to-1 into two arms, arm A being the combination of daratumumab, cyclophosphamide, dexaméthasone, and pomalidomide, and arm B being the same triplet combination of daratumumab, cyclophosphamide, and dexaméthasone with pomalidomide at progression. Patients had to have relapsed or refractory multiple myeloma with greater than or equal to one prior line of therapy. And patients who had previously had daratumumab or pomalidomide were excluded. The primary endpoint of this trial was progression-free survival, and the secondary outcomes of overall survival, duration of response, and overall response rate were included. One thing I think is important to note about this trial in terms of baseline demographics is that the majority of patients were exposed to lenalidomide. Actually, 96% of them were, and 2/3 of the patients were lenalidomide refractory.
What information caught your eye from this study?
I think mostly this was a really innovative study design by using the quadruplet up front and then using the triplet with the fourth drug added at the time of progression, looking at whether we could recapture that response. I think it's really important to be looking at these types of studies, both from a biological perspective, but also looking at cost containment and looking for the most cost-effective ways to use these expensive regimens. I think, the big message from this study is the very impressive overall response rates, which is one of the highest, if not the highest, of the daratumumab and pomalidomide combinations, or I should say monoclonal antibody and pomalidomide combinations. And particularly, it's impressive given the amount of patients that were exposed to and refractory to lenalidomide in this group. One of the questions that came up I should mention is the tolerability of this regimen, in particular the hematologic cytopenias. And it is important to note that the use of G-CSF was permitted in this trial.
I think as clinicians, we're all faced with the dilemma of the best regimen to give to our patients who are progressing on lenalidomide, which is a common scenario for first relapse in myeloma. From a clinician's point of view, what do you think the clinical impact of this study might be?
So I'm biased, of course, because this is our CMRG trial. And so I think it's really exciting having this as a potential option for patients who are refractory to lenalidomide, because historically and with good data, they can have challenging clinical courses to treat. I think that in our population, it is really nice to have an option or a potential option of providing patients a monoclonal antibody in combination with pomalidomide and adding a very, shall I say, cost-neutral drug such as cyclophosphamide in and increasing these overall response rates is actually really exciting. And so I would be advocating for this to be potentially a new standard of care for patients receiving pomalidomide-based therapy in Canada.
Might be interesting to think, not so much in Canada, but in jurisdictions that don't have access to pomalidomide for financial reasons, that the 3-drug arm also did surprisingly well, using cyclophosphamide as both a cytotoxic and probably immunomodulatory agent. So thank you for your thoughts.
Thank you.